Thank you all for joining our third session of the day. We will begin in a few minutes. Hi, everyone. My name is Anna Pilata, and I will be your host for today's third session. On behalf of the American Heart Association, I would like to welcome you to this session titled Designing and Implementing Multidisciplinary Postpartum Cardiovascular Care Programs. This session will feature two model shares highlighting multidisciplinary approaches to postpartum cardiovascular care that support mothers beyond pregnancy. Throughout this session, you will have the opportunity to submit text questions for our speakers using the Q&A feature on your control panel. You may send in your questions at any time, and we will review the questions during our Q&A at the end of the presentation as time allows. To access live closed captioning, please click on the closed caption button found on your screen. All sessions will be recorded and available in the coming weeks. It is my pleasure to welcome our speakers to this session, Lacey Parzadmir and Dr. Martha Tesfula. Lacey is a perinatal nurse and care coordinator at St. Anne Medical Center with extensive experience in maternal and neonatal health. Dr. Tesful is a board-certified maternal fetal medicine specialist and assistant professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences at the University of California, San Francisco. As a reminder, full speaker bios can be found in the event lobby. Lacey, I will turn it over to you.
Okay, hi everyone. My name, like she said, is Lacey. I am the nurse navigator for the Postpartum Wellness and Recovery Program here at St. Anne Medical Center in Burien, Washington. And I'm excited today to share how we built our multidisciplinary postpartum hypertension model. We love this program. I'm very proud of this program. So like I said, I'm excited to share it with you today. Okay. Okay, so like as Dr. Bond was saying earlier, we know that the postpartum period is crucial for managing hypertension, closely for both current and long-term health. So we built this model that aims to bridge the gaps in the postpartum care, improve health outcomes, and reduce disparities for high-risk postpartum women. We focused on the women with hypertensive disorders of pregnancy, postpartum mood and anxiety disorders, and gestational diabetes. We call it the Postpartum Wellness and Recovery Program, or POWER for short. So call it the POWER program. For the purpose of this presentation, I will be focusing on just our hypertension pathway, but just wanted to give you guys a full view of what we do cover. Our approach starts before discharge, centers around a perinatal nurse navigator, and integrates remote patient monitoring. We also provide coordination of care across disciplines. The goal is to create a system that supports patients not just at discharge, but through the entire postpartum period and beyond. This is our model. It's a lot to take in, I know, but it shows our hypertension pathway and how the model functions across time. So before discharge, patients with hypertension or at risk of hypertension are identified by the discharging nurse and the providers. And then they are enrolled into our program, provided with education, and equipped with a remote patient monitoring blood pressure cuff. The patients will set up their remote patient monitoring cuff once they get home, and they'll be advised to start taking twice daily blood pressure readings, which we can see. So it's like real-time response from their blood pressure devices. They can choose not to use remote patient monitoring devices as well, and they can use their own devices. And then we would still provide them the same education and support, but we would have them send in their blood pressures weekly and call us if they're elevated So obviously we prefer the remote patient monitoring, and it has really helped us decrease our readmissions and all that. So that's what we try to do for all of our patients. Over the next 6 weeks, the remote patient monitoring team will actively monitor and triage the patients in real time, and they'll notify me, the nurse navigator, as needed. I'll show you how they decide whether to notify me or what to do with those blood pressures on the next slide. But for now, yeah, that's the care management section. They will notify me if they need to, and then I'll collaborate with the OB to update the care plan as needed. Then I will also reach out once a week or more frequently if indicated by the blood pressure readings, and during each check-in call, check on the patient's mood, because as Dr. Bond was saying earlier, of course, PMADS and hypertension are both like the leading complications in the postpartum period. So I check on that every time I talk to a patient and address the SDOH barriers, as well as, of course, assessing and adjusting their medication plan as needed, and providing additional education on their diagnosis. Then at 6 weeks, we ensure patients are set up with a cardiology appointment for a cardiovascular risk assessment and have established care with a PCP, so that we know that that they're going to continue care, and we can provide handoff if needed, if needed for patients too. And if they don't have these set up at 6 weeks, then the nurse navigator will assist them in doing so. Lots of times this is for the patients who don't speak English or have trouble finding primary care or something. We'll make sure that they have primary care and cardiology before their completion of our program. So instead of fragmented care, our goal is that our patients experience continuous guided support with a clear plan beyond the initial postpartum period. This slide is a lot, so don't try to read it too much, but one of the most critical pieces of our program is having a clear escalation pathway. And I put it in here so you can look at it later with the slides, but for now, I'll talk you through what happens when an elevated blood pressure comes through. This is just here to kind of, so you can see what it looks like, visual. But first, the remote patient monitoring team will contact the patient with a symptom survey if their blood pressure is high, and they will request the patient to recheck in 15 minutes. So they will, if the blood pressure is high, the patient will immediately get a notification, say, do you have these symptoms? And then in 15 minutes, they'll be reminded to take their blood pressure again. Once they take the second blood pressure, the remote patient monitoring team will decide which way to go. If they have moderate elevations, which is 140/90 to 160/110 with no symptoms, then the nurse navigator would get notified and then would review the patient's plan and trends to see if any adjustments should be made, or if it was just like a one-time thing. If they have moderate elevations but with symptoms, or any pressures above 160/110, then the perinatal nurse navigator is notified and the patient is directed to the emergency room for immediate assessment. So that there's no wasted time there. And that's been one of our biggest saviors with this program, is just having immediate interactions with the patient. So if they are in severe range or do have moderate elevations with symptoms, they're immediately guided to the emergency room so they can have interventions before their blood pressures get too high. So the structures allowed us to intervene early and consistently rather than reacting late. And it's helped us decrease our readmission rates by 90%, which is the real exciting part of all of this. So during our program, of course, our main goal is to keep our patients safe and try to improve the long-term health and knowledge on their condition. But we did this by also focusing really heavily on access and equity. To improve access, we offer our support to every patient with at risk of or with a history of hypertension or hypertensive disorder pregnancy. So basically, if we think they have any risk, then we just include them. It's better to be safe than sorry. And then we screen each one of them for SDOH barriers and assist them with resources if indicated. To assess the efficacy of our program, we provide questionnaires to our patients to assess their knowledge and confidence at both initiation into our program and at completion. And we've seen a meaningful increase in patient confidence in managing their health as the scores have gone up 15%. So we provide a lot of education to them. We've also seen improved follow-up adherence to 6 weeks postpartum visits the rate of adherence has gone from 35% to 80%. We attribute that to just the frequent check-ins. When you're checking in each week with somebody or more frequently, then you're able to help them get scheduled and they feel more connected and involved in their care and show up to their postpartum visit. Also importantly, we address the SCOH barriers directly, like providing loaner tablets for people who didn't have phones, or we translated all of our materials into 7 different languages so that all of our patients would get the same education, or not all of the patients, but most of them are able to get education in their preferred language. So by working on addressing these factors, we've actually been able to eliminate the racial disparities in readmissions that we saw prior to the program initiation, which has helped us achieve our goal of trying to make it equitable. These are just a slide that kind of shows some of our barriers and some of our solutions, because I know I can talk about this pie in the sky goal, but in real life, it's always hard to start a program and then overcome the barriers. So what we did here was we started with getting a nurse navigator, which is me, and I was obtained by grant funding. So that's how we solved that one. And we're still working on trying to figure out how to fund this role long term, but we're working on a few different options for that. So we're hopeful. We also had to solve for device like blood pressure cuff access and patient monitoring. So we partnered with a remote patient monitoring program for 24/7 monitoring, and they provided the loaner tablets and the blood pressure cuffs. So that was great. So not all of our patients had blood pressure cuffs. That was something that was hard in the beginning, was not all patients had the money to buy their own blood pressure cuffs. And so we struggled with that in the beginning. Of course, language access. We have a very high percentage of patients that don't speak English. So we had to, like I said, we translated a lot of materials and we used a lot of interpreters. The other one was access to postpartum primary care. Primary care is just busy. Getting people into primary care is hard. Getting them to understand why they need primary care is hard. So we start that education as soon as, basically every time I talk to them, we talk about setting up follow-up care. We talk about primary care and cardiology and long-term planning. So that we start with early referrals and hopefully get them in within the first 6 months postpartum is usually kind of my goal, because primary care is usually kind of backed up. And if the patients can't call and schedule, like if they speak another language, then I'll call with them with the interpreter on the line and just help them get it scheduled to get that going. Because usually just the initiation of it is the hard part. Another one that we faced in the beginning was dealing with complicated cases or sustained hypertension. So patients who we couldn't get off medication by 6 weeks, or patients whose medications weren't working adequately. So we partnered with cardiology to coordinate follow-up, and all of our patients now get referrals to get a cardiovascular risk assessment with the same cardiologist for consistency. So that's been great. Our patients have received lots of education in that way. And then workflow ownership. It was hard to figure out who was going to do what and how the patients were going to get the education in the unit. So we made it an RN-led program where the discharging nurse obtains the consent and provides education. And once they started seeing the results and the decreases in readmissions, all the nurses were on board. So this model directly aligns with the postpartum cardiovascular care recommendations that were already gone over. We've been ensuring early blood pressure monitoring, timely follow-up care, specific medication management, and long-term risk identification. We've taken these recommendations, and that's how we implemented and developed this workflow, just putting it into real clinical settings. Our patient experience. So our patients, we provide patient satisfaction surveys to all our patients, and we've gotten great feedback. We've gotten feedback that this program helped me feel safe and supported after going home, that I truly believe the call from the nurse navigator saved my life, and I am so grateful for this program. And overall, the patient experience surveys have been very positive. People who've had babies before say that this program, and they didn't have it last time, they didn't have this intense follow-up in the postpartum period, say that this time they had a lot less anxiety and felt safer at home. and felt that they would be reached out to if something happened. So they were really happy with that. It was, I mean, that's our goal, is making sure patients don't feel scared or alone during, this high risk period, and focus on taking care of their baby, knowing that we're taking care of them. Okay. I think if I had to narrow it down, these are the elements that truly made it successful. Starting before discharge was critical, getting that education in, and then of course having a dedicated nurse navigator to create accountability and continuity. The real-time monitoring with clear escalation pathways allowed us to act early instead of waiting for the blood pressures to raise. And the follow-up coordination ensured that patients didn't get lost in transition. So it wasn't just one thing, it was kind of how everything worked together. Now the important part is uh, replicability. So that's kind of been our goal this whole time, is try to create something that can be spread so we can continue to support not just our patients, but patients everywhere. So for sites that are interested in implementing something similar, there's just a few essential components. The main one would be probably a nurse navigator role, having somebody to follow these patients and check in and create those relationships. And then the clear escalation protocols, and of course, access to blood pressure monitoring. From there, you can build in cardiology partnerships and SDOH support as resources allow. And of course, grant funding is always helpful. But this model is pretty adaptable, so you don't have to build in everything all at once. That's just how we did it. So that is that. Thank you all. And I'm happy to share more, answer any questions anytime.
Thank you so much, Lacey, for a wonderful model share. As a reminder to our audience, please send in your questions at any time. We will review the questions during our Q&A session at the end as time allows. But it is now my pleasure to welcome our next speaker for this session, Dr. Martha Tesfalu. Dr. Tesfalu, the floor is yours.
Thank you. Just making sure. Great. So I am really grateful for the opportunity to be able to talk about some of the work that we've been doing at UCSF, the University of California, San Francisco, to bridge care from pregnancy to the postpartum period through our postpartum cardiometabolic wellness clinic. I have no relevant financial disclosures, and I'll just jump right into it for the sake of time. I think we've heard a lot of really important context about why this work to support patients in the postpartum period is really critical across the United States. We see unacceptably high rates of maternal morbidity and mortality during pregnancy in the first year postpartum, and unfortunately also increased risk for women or birthing people who've experienced adverse pregnancy outcomes even beyond that first year, with cardiovascular disease being one of the primary drivers. And we know that complications in pregnancy like hypertension, preterm birth, even stillbirth can serve as early warnings for future cardiovascular risk. We know pregnancy can function like a stress test for the body, and yet we sort of think about postpartum care sort of just in those first few weeks postpartum instead of recognizing postpartum is forever. And we have a really important opportunity in the postpartum period to really set patients up for success with prevention of long-term health complications at a time where patients are often deeply motivated to improve their health, but also face significant barriers, particularly around, as we've heard, fragmented healthcare systems, childcare responsibilities, transportation issues, insurance transitions, and even just prior experiences of not feeling heard, perhaps during their own birth experience. So this work is really important. I'm very thankful for the AHA for giving us the opportunity to think about how we build trust, think about these systems changes, and how to create culturally and responsive care for our patients. Just to share a little bit, hopefully folks have heard about UCSF. We're an academic medical center based in the Bay Area. We have a few hospitals within our umbrella that we receive patients in, and many ambulatory sites, as well as partnerships with hospitals and other systems like Alameda Health System, where I am today. And within our obstetrics department, we have a number of different providers who take care of patients, including midwives, nurse practitioners, general OBGYNs, and MFMs like myself. And for our higher risk patients, we've developed a number of specialty clinics, including our pregnancy and cardiac treatment clinic, which has been in existence for years to help take care of patients who had rare congenital heart disease or maybe acquired structural heart disease. But we really noticed in recent years, as more data has come out about the increased risk of cardiovascular disease later in life, that we didn't really have the best home for patients who may have experienced an adverse pregnancy outcome and had increased risk of heart issues in the future, but didn't have it currently. And so we wanted to respond to that. Our goal was not to just design another clinic, but to really think about designing a response that was going to meet patients where they are. As we've heard, hypertension is one of the huge drivers and an important thing for us to help manage patients through, especially in those first few weeks postpartum, where there can be a lot of fluctuations, a lot of risk. And so we started an outpatient postpartum hypertension clinic that is run by our amazing nurse practitioners who get referrals on discharge from delivery admissions for all postpartum patients who had a hypertensive disorder, be it chronic hypertension, preeclampsia, gestational hypertension, or just an elevated blood pressure leaving the hospital. They will follow patients up to 12 weeks postpartum to help with medication titration, education, helping transitions to primary care. But what I'll focus on for our time together is our postpartum cardiometabolic wellness clinic, which we started as a joint venture between our divisions of cardiology and internal medicine and our division of maternal fetal medicine and reproductive genetics within our OBGYN department. And we really focus on patients who are higher risk, not just because of hypertensive disorders, but sometimes because of other adverse outcomes that they've experienced in their pregnancy. We hold these patients for the time when they transition out of sort of routine obstetrics care into 1 year postpartum and are really seeking to provide holistic cardiometabolic care. And this work would not be possible without the people. So I'm just one of many. I want to highlight Dr. Phoebe Ashley, who I think we would all agree is the true heart of this clinic. We were very excited when we recruited her as a professor. Her whole passion is to really help support women across their lifespan, particularly mothers who have experienced complications. Alongside her, one of our newer faculty, Dr. Megan McLaughlin, sees patients, but also is our cardiology research lead, and we'll talk about some of the work she's already started to do. And then we're fortunate to have our director of nursing for cardiology ambulatory services, Amanda Schnell Herringer, be our backbone, make sure to check in and hold patients between visits. In our MFM department, I get to serve as the lead of this clinic. And with me, I bring my experiences as the Black Wellness Clinic, maternal fetal medicine faculty member. I also work as part of our pregnancy after loss clinic. We do know stillbirth, unfortunately, increases the risk of complications. So that has been a powerful combination of skills to bring to this space. Dr. Juan Gonzalez Velez is our division director in maternal fetal medicine, an amazing leader who's in many different clinics, not even all those that are listed here, but serves as a bridge to our pregnancy and cardiac treatment clinic, as well as our Latin high-risk OB clinic. Dr. Christine Blavelt is one of our new faculty. She serves as our MFM research lead in this space, really has a passion for both patient level data, but also does a lot of really interesting basic science work. I'll highlight Danielle Briggs. Even though she has not been able to come to see patients in the clinic, she serves as an invaluable lead of the outpatient postpartum hypertension clinic that I mentioned, which is a direct feeder often into our space and also helps lead our post-pregnancy after loss initiative. And Dr. Divya Malampati, who has transitioned back to UNC before we started the clinic, was integral to the initiation and planning that I'll talk a little bit about. There was a lot of prep work. So when I say Dr. Malapati was involved. She was involved in some of the work that we were doing for, over a year prior to our first clinic, a meeting after hours to Tuesdays from 5 to 6 to really come together, meet each other, think about what our vision was for this clinic. And we really wanted it to be informed by patient voices and experiences. So Dr. McLaughlin did a lot of really important interviews with patients to understand where they felt like the gaps were, what they still had trouble understanding, what their fears were, to see how we could best address that. We did look at the literature. We looked at our own institutional data. We reached out to colleagues in primary care to create some of those pipelines. As Lacey mentioned, that can be a hard channel, but we wanted to have it for our patients. And other teams like weight management to learn about what we could bring into our clinic. And then I think importantly, we wanted there to be, a good infrastructure for sustainability. So a lot of the work that took more time was developing MOUs and thinking about how to develop billing infrastructure, those kinds of things. When we started the clinic, we started with a fewer number of slots, and so we focused first on the highest risk patients, as listed here. Things like experiencing eclampsia, recurrent preeclampsia, are of concern. Patients who had other adverse outcomes were included in phase 2, and we're now in phase 3. We're thinking about broader expansion of our services. So in terms of patient flow, sorry, I'm having trouble with these slides. Patients are referred to our clinic through cardiology. We initially have our first visit with them within the first 3 to 6 months, and the visits are held jointly between cardiology and MFM. We work to then at the end of our time with the patients to transition them into primary care. And many patients actually qualify for having ongoing care with cardiology as well. We launched in March of last year. We started with 2 Monday mornings a month and quickly realized that we needed to expand. So we're currently in the spring of 2026, and we've already increased the number of sessions that we're holding by 3-fold. And we anticipate by September a 5-fold increase with full day a week of this joint venture. And I'll just highlight that the clinic is physically held over in the cardiology space, which some patients have noted was really helpful, especially if they experienced adverse, events during their pregnancy, to not be in a waiting room with a lot of pregnant people. We do pre-clinic review, we do vitals, EKG for every patient on their first visit, and then the visits actually happen concordant. So a cardiologist and an MFM is in the space with the patient and their family or whoever they have to support them. We sometimes have trainees like preventative cardiology fellows, nurses, or a pharmacist with us, but that allows for shared learning, not just of the patient and those who are supporting them, but also of us as the providers. And we are able to leave those spaces with a shared plan and of how we're going to support these patients moving forward. Being in the cardiology space also allows us to facilitate more scheduling more easily as well for things like cardiac studies. And we also check in between visits, of course. We are involved beyond the clinic itself. We're grateful to be part of the AHA's Learning Collaborative, where we partner also with our community partner, SisterWeb SF Community Doula Network. We're doing trainings of their doulas around how to support patients who have risk factors for or who have cardiovascular disease. We're also part of SMFM, or the Society of Maternal Fetal Medicine's Hypertension and Pregnancy Change Initiative. And we also want to make sure patients are supported with resources at home, so have worked to get funding and things for BP scales, BP cuff scales and cookbooks. And in terms of where we're going, we still want to build more bridges. And one of the things that we're actively in discussions about is shifting our name from postpartum to really thinking about perinatal care. We're already having conversations with patients about future pregnancies. Is it safe? Is it not safe? And have started to receive even preconception referrals before explicitly expanding. But we also recognize that there are efforts in the pipeline to better identify patients, and we want to be there at the table to help support. UC we're going to be looking to implement CMQCC, which stands for the California Maternal Quality Care Collaborative's cardiovascular disease screening tools. There are already sites in California that have implemented this into their EMR. And so as we sort of better screen patients, we know it's important to not just identify issues, but get patients plugged into care quickly so that they don't feel scared, but empowered with the information that they receive. We also are going to engage more providers, are seeking to think even outside the box about who can be part of this clinic and what other sites we can do. We're planning to do group sessions so moms can meet each other, grand rounds with other departments so that providers can learn more and expand the skills. And then as I mentioned, research is a big part of it. And so hopefully in the future, we can present some data like Lucy did amazingly. And I'll just end by saying, I think this work hasn't been easy. We had a lot of plans that, sometimes got diverted or didn't go the way that we had expected. And I'm by no means sort of suggesting that we should get rid of plans. They're obviously critical to the success of any initiative, but I think what really has moved us forward is the heart of really wanting to show up for families, especially those who maybe we've taken care of, who've experienced something hard, and really make sure that we're setting them up for success moving forward. So I thank you for your time and I look forward to questions.
Thank you so much, Dr. Tesfalul. And thank you again, Lacey, for your 2 wonderful model shares. We have time for one question. I think this question is for Lacey. How do the recommendations or resources change with substance use or NAS?
That's a hard one because it depends. It's very individualized. It depends on the patient and how much they want to work with us, I guess. So overall, we have a good team of providers and everybody works together to do what we can for the patients. But our plan kind of overall remains the same, just really frequent check-ins and making sure that they have the support they need and connecting them to more resources if they need them, and getting them connected with our community health worker as well or other resources. So yeah, overall, it's just more collaboration with everybody, I think.
Thank you, Lacey. We are unfortunately at time. So I want to thank Lacey and Dr. Tesfalul again for 2 wonderful model shares. And thank you to our audience for your participation. Coming up next at 11:25 Central, we have our 4th session of the day titled Stroke Prevention and Response in Maternal Health, Insights from the New American Heart Association Scientific Statement. To access, we have posted a link in the chat to join directly. Thank you very much for attending today's session, and we will see you shortly.